All right, hey guys, super excited about our live today with Dr. Wright. Let me write here, write your questions below. I love it. I'm very excited. A lot of questions that I've got. Okay, so I'm gonna wait for Dr. Wright to join us so I can accept the invitation. See a lot of people here. Let me see if I can find him to send it. Awesome. So we're gonna talk about, oh, that he is. Okay. I have a list. Let me see. Yeah. So I accept it. Perfect. Dr. Wright, how are you doing?
Great. Good to see you.
Good to see you too. I'm so excited for this live. I've been getting a lot of questions for you.
I'm raring to go.
Are you ready?
Yes, I'm ready. Yeah.
Well, first I'd like to thank you for the invitation to the FDRS. I'm honored and grateful and thankful for the opportunity. And for our audience here, if you guys, the FDRS is anything related to fat disorders, it's Dr. Wright, a lot of great minds in that society, anything related to lipedema, Durkheim's disease, you name it, they talk about it, research, a lot of publication, a lot of science. I mean, it's just, you gotta check it out. And this year it's gonna be in St. Louis, correct, Dr. Wright? And go ahead, tell us a little bit
Well,
about it
yeah,
for our
no, so
audience.
it does have research and it is lipedema, as you know, is the most common subcutaneous adipose disease, and that's really the most of the people are there for lipedema, but a very closely related disease also Durkheim's, and then and sometimes it really is hard to distinguish between the two, and then one other fat disorder called multiple symmetric lipomatosis or Madelung's disease, and those really so there's going to be talks, scientific talks, but just as much is it's just going to be patient based, and there's going to be patients who are going to speak and patients who are going to who are in there to participate and get commonality, kind of share tricks and see booths and all sorts of things. So it's all these resources for women with lipedema, and so it's very of course, more of the people that attend are actually patients and also other providers like lymphedema therapists and physical therapists, that those sort of things that help care for or interact with lipedema patients.
That's awesome. And I have almost a lot of our patients either have been to FDRS, and a lot of even in when we were in Germany, a lot of people were talking about it, and it's impressive what you guys have been doing on that, adding so much value to not only physicians and it's mainly to patients to get more awareness, physical therapists as you mentioned, because it does take. I mean, it's not just fat; it's like an entire spectrum of things that. Right. That really we need to have. So big congratulations, and I know it takes a lot of hard work to put a conference like that.
And so and one other thing, there's also, we emphasize diets and things like that are helpful. Yeah. So and yeah, so I'm really excited about that. It's going to be great. I lucky to have it in my hometown, and I am it's always, I always learn I always learn and from my fellow colleagues and from patients, and just how to better understand and treat this disease.
Thank you. All right. So as we're talking, we've been getting like few questions, so we can start. First, you're getting a lot of hellos from Argentina, Brazil, pretty much from all over. The first question we have here is about the diet, and I know you kind of you spoke about that kind of last time, and we can. Nadia is asking, is keto diet suitable for lipedema? What's your thoughts on that?
Oh yeah, so yes, very suitable. In fact, there's some studies showing its effectiveness. So I think keto is really can be very effective, and we're just learning more about these. There was just a study just in the last week about from the Nurses Health Study about increasing protein and how it has benefits. But if you look into the details of these studies, both from on lipedema and in the general population, plant-based protein is probably preferred. But and again, that's lower in the carbs. And even if it's not full keto, a low refined carb is going to be the healthiest diet.
And there's a lot of, and I've been seeing that there is some shift, Dr. Wright, in terms of more and more people I see either they're doing a pure, not even just like either the red meat diet or they're just like a pure protein diet, and it's some patients are saying it's working a lot, but I'm kind of with you. I think the sustainability is going to be key for them.
Right.
And like, can you do it for 50 years or 20 years or 30 years? I think that's going to be the main question.
But so there's a minority of patients who can stay on a pure keto diet and do great. And so I think I don't think this is like, I don't want to say there's you have to go to just a plant based, because in a pure keto diet you're going to have less plant protein and probably more animal meat protein, and dairy protein are probably going to be a bigger part of it. But so those are all effective and helpful.
Yeah. We have a question here from Maria, and I think that's since you do veins as well. She's asking, what if you have varicose veins with lipedema? What can be done? It's very painful. What's your thoughts, Dr. Wright?
There is a higher prevalence of varicose veins in women with lipedema, and if they're significant, they should be treated. If they're bothering you, if the vein themselves are tender or they're large or something like that, they should be treated. And there's vein doctors all around who can address that and treat that. And yeah.
So let's say somebody who has, as you mentioned, the varicose veins and lipedema, that kind of like, that you're more commonly to see them in lipedema patients. What do you do? What do you treat first usually? You treat the veins and then liposuction, or?
Yeah, so I'm always going to treat the veins first, and there's several reasons for that. One, I mean, the biggest is large varicose veins, or varicose veins can increase the bleeding after the surgery, and that can be, these are relatively large surgery volumes are removed, and so that can be significant. I in a recent publication, about 5% had a drop in their hemoglobin after the surgery, and that's even after treating varicose veins first. So if they're significant, we always recommend treating them first. There's also a network. Shelley Crescenzi at Vanderbilt showed that there's a network that occur of veins above the knee that occurs really only in lipedema that we see, and so that can lead to a lot of knee pain and pain in the leg. So yeah.
Yeah, and shout out to Shelley here. She's awesome, and she's doing a lot of great research on lipedema, and that's interesting because with varicose veins, and like I see there's different school of thought. Some, and obviously like some people treat it before, some people treat it after, depending on the skill set for veins, and Different people are different, but it makes total sense. Like somebody who is, especially if they're starting with a low hematocrit, they have very large veins, then the odds, then they're gonna need, they're gonna drop, like you said, 5% at least if you add the hemodilution, and if they have high veins, and if they have high menses, they bleed a lot. So there are certain people where I think the treatment can be beneficial beforehand.
Yeah, but not every, someone with just a little varicose vein somewhere doesn't necessarily need treatment. Within reason, like we're both saying, yeah.
Yeah, I agree. Kancha is asking, I add lentil and low carb, and that's more sustainable. Do you think that's okay? Adding low carb to her diet and lentil?
Yeah, I think that sounds like a great diet.
Awesome. Maria is saying, thank you for answering my question. I really appreciate it. Much love. Um, you're welcome, Maria. We love what we do, kind of. That's what we do. Another question we have here is about insurance. They're asking about, is Lipedema covered by insurance?
It is more and more, and I mean, I would say most insurances now. The one that really does not cover the government insurances, Medicaid and Medicare, do not cover it or cover. But most of the commercial insurances are covering it. Not all, but some. And you have to understand, just because, and they'll, if you call them and they have some possibility of coverage, they'll say it's covered, but they have medical necessity criteria, and they are pretty strict about that. And they will, I mean, I've had people that you know I mean, I feel like it should be covered by everybody, but they have strict criteria for the size and stage, and certain conservative treatments like compression and weight loss attempts and stuff like that. And so those so not everybody gets coverage, even when the insurance company does have a policy. But we're getting more and more. I would probably say close to 80% of our patients were getting coverage for that, for their lipedema surgery.
That's awesome. And you feel this percentage is higher than it used to be a few years ago?
Oh, for sure. Yeah, it's increased significantly. And that one last little caveat, because I feel like I don't want to mislead people. They You still have to meet deductibles and co-pays and stuff like that. So there's that, even when it's covered, it's not, it's still it's still not free. They still get you.
Yeah, I agree. The other question we have here is about staging the procedures. What's your thoughts on that? Kind of like, I mean, what I mean by that, like, would you do every 6 weeks apart, within the same week? How do you address?
So yeah. So it's every patient's individual, okay, but most of the time we separate it at least 6 weeks. And so and it comes, now there's a few times on rare instances, like they're smaller and we're removing smaller amounts, might do them more frequently, but I would say 6 weeks. And some people, just because of their schedules or convenience, or maybe their finances, they separate them more.
Yeah, yeah, I agree. I think 6 weeks in general is like a good safety zone for the body to recover, to get more blood count back to what it needs to be.
Yeah.
Talking about the blood count, do you have any cutoff where, like, below that you wouldn't do it, or you put them on iron? How do you look at kind of like CBC, hemoglobin, hematocrit?
Yeah, so we look at hematocrit, and I mean, if they have significant anemia, yeah, that needs to be addressed before the surgery. but a little, a little bit of anemia is well tolerated. And if they develop anemia post-operatively, then we will recommend an iron supplement.
Yeah. I was talking to a colleague of ours in Germany, and I didn't know that he was telling me that if the hematocrit or hemoglobin, he was saying if it's less than 11 to 12, ideally less, they just wouldn't operate. And I don't know, is that your experience here in the US, or how do you, what's your, and I know you look at hematocrit, that would be basically 36 for the
No, yeah,
hematocrit.
yeah, no. I mean, did I say hematocrit? I meant hemoglobin. And but I mean, we look at it. I'd say that's not a problem that occurs that often.
Yeah.
So
Same here, because like sometimes the thing is, some women they live at a low hemoglobin, they live at
yeah,
11, and it's very hard. You like we optimize them iron, vitamin B12, and no matter what, sometimes it's very hard to get them out. The key is minimize blood loss and the surgery, like good tumescent, good surgery, or treat the veins if they have large veins that are sensitive, prone to bleeding.
yeah, yeah, yeah.
Awesome. All right. Next question we have here from Kancha is I have type 3 stage 4 lipedema. Do you think at this stage liposuction will help? I'm from India and I'm a bit scared.
Well, I mean, that's where it gets a little tricky. If so, depending on BMI or weight, you can be a stage 3 lipedema, and I only believe, by the way, there's only 3 stages. So I, we for us, it's there's lymphatic impairment at all the stages. Even some people with stage 1 lipedema have lymphatic impairment, and then stage 2 there's a higher percentage, in stage 3 even higher. But so we don't so a stage 4 is when there's supposed to be lymphatic impairment. Well, it doesn't really fit with the staging. So to me, there's 3 stages. So I'm going to talk as though she has stage 3. But I, at the when there's a secondary obesity, there's times when in BMIs or 50 or above, we often recommend weight loss before treating the lipedema. But that's variable, and I think we talked a little bit about this before, is that if they have if all their weight is in their hips and thighs, then maybe we would treat that, but yeah.
So let's say somebody like her at this stage, so you'd recommend like weight loss and then potentially liposuction
Yeah.
after that. And walk us through like the stages, Dr. Wright. So the way you look at it, so you look at it stage 1, stage 2, stage 3. Lymphedema is within all
It
stages.
can
Some
be,
sort
yeah,
of impairment, obviously more than stage 3. So how do you differentiate like stage 1 from stage 3? Is it the quality of the fat? Is it the
yeah,
skin?
yeah. Those great. So stage 1, the skin is still smooth, and you can feel the nodules, but there's not much mattressing, and the and then at stage 2, you're going to have the lot nodules are going to be larger, and then you're going to have more um, uh, more cuffing, and more the beginnings of lobules. And then stage 3, lobules are present, and so that's really that's how those are the big cutoffs for the staging,
Yeah.
and so
And it makes sense.
yeah.
Other question we have here from Lippy like me. Is there any hope for other treatment options in the future? Perhaps a medication. My concern is progression despite conservative treatment and lipedema reduction surgery.
Yeah. I mean, I mean, yes, there's just there was an exciting paper in Nature. I think it came out last week about how they're looking at um, exosomes and how they are influencing fat cell metabolism. And so, I mean, this is something that's getting looked at, and we're always looking at other treatments, and and we're also, we talked a little bit, you know, we're looking right now at these GLP-1 and whether they might have, in addition to their effect on weight, might have an additional effect to the inflammation in the subcutaneous fat. So that's might be, again, we don't, that's just, these are just hints. I am not saying that these are there's any proof of that. I'm just saying that these are things that are currently being looked at.
Yeah. Another question here from Akshla. She's saying basically the same question. Is there any medication that you know of that's you just answered this question. So for the GLP-1 agonists, and the more and more we see more people are, you know, are taking some sort of, you know, GLP-1 agonists, and they are having, you know, good outcome. However, there's like few reports about the side effects that's starting to show up. What's your thoughts on that?
Well, I mean, they are a medicine that can have significant, especially GI side effects. And then there's some look. I mean, they were thinking about even stuff in terms of depression, but that didn't turn out to be so. But I mean, they have, you know, can cause nausea, vomiting, diarrhea, and too rapid a weight loss that they lose muscle mass. But I was going to say one more thing. So there are a couple. So we did. I did a study with diosmin, which is a supplement, and it helped ladies with lipedema. So it's an extract of citrus peels, and it was helpful in treating lipedema. And then there's also, I mean, some people, the Mucinex, I don't, and so have had some benefits in terms of pain and feeling the tissue feel softer with the Mucinex.
Interesting. So Mucinex as like regular, like PO Mucinex.
Yeah. So yeah, like guafenicin is the drug name, but yeah, the it's sold as primarily as Mucinex. Yeah.
That's awesome. I love how you're so versed on the research side, and kind of like, you know, it's just like your mental capability and knowledge about lipedema. I'm always amazed. Like, I'm actually more excited about this life to learn about it as much as our audience.
You are way too kind. I mean, it's been my passion for years, and so, you know, this is something I, you know, I really, you know, I lean into and follow very diligently. Yeah.
We appreciate you, Dr.
You're very kind, though. This is too kind. Too kind.
You're so sweet. I see a poster behind you. Can you tell us about
Yeah.
it?
So this is the poster. This is a can I move this?
Please,
I don't
please
know.
do. Yeah, absolutely. Yeah.
So this is a poster of for the paper that we published in PRS Open Global, and this is just showing the range of. So up here are the physical, the domains of health, including general health, pain, etc., that we looked at, and all 8 domains showed improvement. And then this is the knee flexion, which we saw about a 10% improvement in knee flexion after the lipedema reduction surgery, and an improvement in gait from 20% to 80% having a normal gait. And then just around the edges are just before and after photos, like before. So we also saw a significant decrease in lobules. And so like this, I don't know if you can see the internet.
Yes.
No, you can't see that.
Yeah.
So let me point towards. Oh gosh. We're gonna get in trouble. I'm getting in trouble now. Right over here.
I love it.
So you can
Yes.
see that before surgery there was lobules on the knee, and after they resolved,
Yep.
and so about 80% had a lost these lobules. Well, that's potentially because lobules are one of the key factors for the differentiation between stage 3 and stage 4. um, it could be argued that they had a regression in their stage of their lipedema from the lipedema reduction surgery.
Mm, this is awesome. So, I mean, that's a lot. Like you proved here multiple things. You proved the range of motion of the knee is better. The gait is significantly improved, 20% to 80%.
Yeah.
The staging kind of going back. I mean, that's awesome. And that's impressive. And I love like you know, you're going the scientific way, the publication way of a clinical improvement and data, and just to prove it, that's a big deal. It takes guys a lot of work to get to this level. Like it's a lot of work behind the scene to get this out there.
Right. Yeah. And we've had, to be fair, I mean, my staff and my patients have all, helped along the way. I mean, we do all these extra measurements and all these extra surveys on our patients, which they have gladly done and cooperated with. And then my staff, I mean, they collect all that stuff. And then then my work becomes looking at the statistics and writing the papers, but I can't do it without the help and cooperation of my patients and my staff.
Absolutely, absolutely. Lippy like me is asking. I know for myself, I'm at a normal BMI, even though I'm stage 2. Doctors will not prescribe me GLP-1 agonist. So, what's your thoughts on that? Kind of like,
Well, I mean, I feel like, I feel like if they're the insurances are this is really coming from medical insurance don't want to pay for these, but I feel like if there could be, if your doctor, if you and your doctor decide there could you the benefits outweigh the risk, I think they should be given, offered and given. I think some of the doctors are reluctant just because of all the hurdles of prescribing, like they patients may not understand how much work they make us go through, and that is completely uncompensated, and then often it results in a denial anyways. And so it's really, our healthcare system is so broken, and that's, I'm sure there are people that would benefit from these medications that are not getting them because of the barriers and the hurdles and stuff that insurance makes.
absolutely. And I totally agree. I think it's more of a healthcare system problem than just a dedicated doctor problem. Um,
Yeah.
all right. Next question we have here from Jessica. She's asking: is surgery a permanent solution, or are there other treatments that are needed after surgery?
Well, so that's a great question, and so we we followed our patients for multiple years, and they have not. I mean, the vast majority of them have not had any recurrence or progression. Now, another now we're very focused on, as you can tell, on diet and lifestyle, and we ask people to continue that. And I think then also Baumgartner in Germany, one of Schmeller's partners, Baumgartner, has now done 12-year follow-up, and they are not seeing recurrence or progression. But Dr. Herbst and I, and Dr. Schwartz published a paper on following up of, in the United States, we're seeing more of that. And I think that's partly because we treat just treating it as simply a surgical procedure that without the the lifestyle changes and conservative measures that really need to be maintained.
Absolutely, I agree, and I think it's like the surgery is part of it, but also the healthy lifestyle and all that stuff. But the
Yes.
common question we get asked is the regrowth rate. Like, I get asked that question all the time, and are there like any percentages out there that we can share with the audience? Say, hey, the regrowth rate for lipedema after a well-done lipedema surgery, is it 2%, 4%? I mean, do we have those percentages?
Well, so we don't by in I think I honestly think it varies by individual surgeon, but I don't I can't I can't I don't have evidence to support that. I just that's been my experience.
Yes.
But it was in the study we did with a survey of women in the U.S. who had it. It was like uh, it was under 20%, but it was more, over 10%. Now, again, like I said, in Baumgartner's series, they had like less than 1%. So it really is. It really is. Again, they do also. It is also related to diet. I mean, I think that's the biggest factor, the biggest difference. Spending a lot of time in Germany, they have no fast food over there. They have, and they walk everywhere. So I think that really helps, ensure the maintenance of the surgical improvements.
Yeah, and I agree with you. I think if you go to somebody who's specialist, who's experts, and that's what they do, the chances of regrowth is gonna be lower because
Right.
like what you're doing. That's what you do all day, every day, and that's kind of you're gonna give them the best outcome possible with the least chances of regrowth. If they go to somebody who doesn't, they're gonna leave significant amount of lipedema fat, and that fat's gonna be more prone to regrowth than somebody who got the right surgery from the get-go.
For sure, yeah.
Jessica is asking, is actually, it's a comment like, thank you for your answer. Love this approach. In terms of kind of like the afterwards, kind of the what needs to be done. Lippy, like me, is saying it seems many patients talk about regrowth or progression with menopause. Do you find lipedema to have a hormonal influence component?
Yeah, for sure. It seems to get worse at certain hormonal milestones. Puberty, pregnancy, and menopause. So yeah, but we don't fully understand it yet, and we're not even sure whether it's progesterone or estrogen or what exactly is driving that.
Dr. Wright, I've had few patients who would mention that like their lipedema, they would notice that even before puberty. Have you had patients like that? They would say, hey,
No, and yeah. So you can see some of the changes even in girls before puberty, right?
what's the youngest you've seen?
Well, I personally haven't seen this, but Emily Eicher has a like a her she published about a 6-year-old girl with some changes consistent with lipedema.
Yeah.
Yeah.
I've
Okay.
had,
Well, she started at 6, but then even by 13, she for sure had it. Yeah.
yeah. I've had,
Oh,
sorry, go ahead.
yeah. Oh, and I was saying ours is 13. Ours is 13 is the
13.
youngest we've diagnosed it in. Yeah.
Okay, yeah. I've had the patients who kind of send me out pictures that even at the age of 7, you can see kind of like, the element of that. And I've consulted with you about a patient who consulted with me, haven't operated on a 14-year-old. And kind of I was getting your opinion about like, what to do, how would you treat those? And let's kind of discuss, for our audience here, because it's a very controversial issue, right? I mean, you have somebody younger than 18, they have lipedema. The father is a physician, actually. And, we're all, kind of like, you think I was like, okay, if that was my daughter, how would you address it? Like a 14-year-old stage 2, would you wait? Would you start conservative? And what's your thoughts on that?
for sure, I would really start the conservative and really lean into it, and only if she was, significantly symptomatic, because I feel like you need to set that. You need to make the priority is going to be the diet, the exercise, the compression, and then but I think in cases when they're doing all that, they're symptomatic. I think it's reasonable to do the surgery, but I think that should be, the accept a rarity, not a because I feel like it's so the you're going to get you can get so much benefit from just the diet and conservative measures.
Do you have a cutoff where you'd say, hey, below this age, I wouldn't do lipedema reduction surgery on?
I think the youngest patient was 18 or 19 I've done surgery on. But I mean, I don't, again, in an individual case, I think I think it could be appropriate earlier. I just have not, that's not, I haven't had that. Yeah.
What about in terms of tolerance? Like I know you do tumescent anesthesia.
Right.
It's kind of like, and I know kind of with both kind of on the awake side, and then like
Right.
how do you feel like people at a young age? Because I'm with you. I've never done it on somebody who's below 18 years old. So I'm not familiar from a how well they can tolerate it from an
Right.
awake
Yeah.
standpoint. What's your thoughts on that?
Well, I mean, tumescent anesthesia is very well tolerated, even in the young. They are, generally, you still have to, weight-based limits, but that's, yeah, they actually do great. They're better metabolizers of the lidocaine. So, they can, they're gonna usually sail through it in the younger patients, is my experience. Yeah.
Yeah, which makes sense. Do you with you the awake? Are there any PO sedation, IV sedation?
So we do. Everybody gets PO sedation with lorazepam or Ativan, and some get other sedation. Sometimes we've used sometimes we use IV ketamine, and we use nitrous oxide laughing gas regularly.
Yeah. Okay. We're kind of like, the same, I am very similar. Since we talked last, I used to give them one Xanax, one Percocet, and we kind of like recently shifted to purely awake, nothing else. And I found they did better with purely awake, which was like kind of really very interesting. And I'm going to talk about that in the FDRS just to kind of share what we're doing that's been working different. Like, like there's so many ways of approaching it. And I'm also looking to learn so much from so many people who've been doing it for many years, way more than I've been doing it. Just kind of like learn some tips and tricks. So I'm excited for that.
I have an experience. I have a nurse that we've done it with oral sedation and without oral sedation, and she preferred it without the oral sedation. But I'm always, I want my, I mean, I'm very strong patient. I really want everybody comfortable. So I'm a little, and my nurses say I'm almost to a fault. Try, like any, I don't want them to have any discomfort whatsoever. And so.
You want them to have a great experience.
Yes.
You want them to come in.
Yes. I would just feel awful if they had anything other than a good experience. Yeah.
Absolutely. And that makes total sense. We're actually looking into virtual reality. There's a plastic surgeon.
Really? Yeah.
During awake. So that's plastic surgeon. I don't know if you've heard of Wallant, wide awake, local anesthesia, no tourniquet for hand surgery.
Yeah.
So he does hand surgery awake, and him and I were talking, and what he does, especially for kids, like they have trigger fingers, like he puts the virtual reality on. It's like called Waiver, and he's like, it's impressive. They just don't, they're like in their own world. So we'll try it. We'll see. I mean, it might work. it might be a disaster, but we'll let you know kind of
Well, yeah.
how would that
Well, and
how would that work out.
yeah, I'm really interested in that because I mean, anything, you don't want any more medications than you want, than and every, you know, every medicine has a side effect, at least at some level. So yeah.
Yeah. So we'll see. We'll see. My worry about it is the nausea, kind of like, if there is a lot of move, because some of it
Yeah.
is like they're skiing or bungee jumping or they're swimming or on the beach. So with the laughing gas, with the Pronox, because it can cause some
Yeah.
nausea. So we'll see. We'll try it and then definitely I'll let you know. Let's keep on going here over the questions. Jessica saying I can definitely appreciate the less meds. Absolutely. One question here is, where's your location? Where are you located?
I'm in St. Louis, Missouri, right in the center of in the U.S. Yeah.
Awesome. My wife did her she's internal medicine, and she did her residency at SLU.
Oh yeah.
Um,
Yeah.
so I've been there many times, and I loved it. It's just an awesome city.
I'm actually collaborating. I'm doing some research with SLU right now on lipedema. Yeah.
Really?
Yeah.
Tell me more about it. What type of research you're doing?
Well, we're following the metabolic effects of diet in lipedema, and so yeah, so weight loss and so I don't want to bore, but okay. So what we found is that so lipedema ladies are extra sensitive to insulin. So the opposite of diabetes, they actually have a increased sensitivity, especially when they're especially when they don't have a secondary obesity. They are actually more sensitive, and so we did euglycemic insulin clamps and such, and then when they lose weight, they do lose weight all over, but always more in the abdomen, and they even get even more sensitive to to insulin and so it's very interesting.
Maybe that's why the low sugar. I mean, this is very. I mean, that research can be. I mean, it's going to open eyes to a lot of things that we don't understand about lipedema.
For sure, yeah.
How long do you think it's going to take?
Well, we're getting the stuff together. I mean, we may actually be publishing this year.
Oh wow!
That's what's hoped for. Yeah.
Okay, so you've done the study, whether you're in the process of the
Yeah, I
publication then.
think we stopped enrolling, and so we've been doing this for 5 or 6 years. But
Oh wow!
it started with WashU, but now one of the investigators is also at SLU, so moved to SLU. You know how that goes. Same town, just different university.
Yes, yeah. Oh, I know how it is. Silvana is asking, do you perform a leg lift after the lipedema surgery? I have stage 3, have had torso, arms, thighs, and calves, ankles surgery.
Well, are you going to answer that, Dr. Salameh? I don't do leg lifts.
Yeah, but same here. Like I don't do any skin resection. All lipo. And I am happy to answer that. So with leg lifts, I think once you take all the fat, not everybody needs a leg lift, depending on how early of stages you are. So I tell them it's a spectrum here. So if somebody has 100 pounds massive weight loss and there's like more than 20 liters of lipedema fat in the thighs, 100% you're gonna need skin resection if you want tight skin. And if you're stage 1 who has 3 liters of lipedema fat, you're not going to need skin resection. And you have everybody else in the middle. For us, I used to do skin resection in the past, but what I found out, thigh lifts at a higher risk at skin separation, wound infection, opening, all that stuff.
Right.
And almost all our patients, they fly to us. So what happens is if they had a minor issue, if they are in town, it's easy to take care of. But let's say if they have a minor issue and they are like, across the country, it becomes such a big problem. Now they don't have their physicians, etc. So then we decided, you know what, it's just like, if the patient wants it, I would say for everyone, do it local. Find the right surgeon for you and then do it in your city. It's the best way possible because these surgeries have high risk of not of minor complications just because it's a long incision,
Right.
skin's gonna separate. You're gonna need a lot of hand holding, and if your surgeon is not in the right geographic location, it's a headache on you. So that's my approach,
Well,
right?
I'm the same way, and I know, and luckily I've been doing this long enough. I know certain surgeons in across the country and locally who are gonna take care and make sure that they protect the lymphatics, because that's also a potential injury from because you're the incision's very close to where the lymphatic collectors
Yes.
run, and so yeah, I think I some people, I agree, it is a minority. I mean, I'm going to say it's probably less than 5% of my patients do get thigh lifts, but I but I um, some need it, and they and I refer those out.
Yeah, yeah, I agree. I'm with you, like 100%. One question here from Lippi. She's asking, can you tell by looking at a patient if they would need skin removal? I had a consultation with a surgeon in Chicago, and they suggested legs, arms, and tummy tuck at the same time with lipedema removal.
Yeah. I mean, that's a lot of surgery, and that the risk for complications from that those total body things are higher, or they're much higher than treating it. You honestly you can't tell. A lot of times you're not. You think they might need a lift, and then it turns out they don't, because their skin retracts on its own enough. So there's a lot of times. I mean, I I don't. First of all, it's always better to do the lipedema reduction first, because that then it's gonna have lower complications, and then some. And so many of the times the skin will retract enough on its own with the compression that you don't. Even when you think you might, going into it, you find out that you didn't. Now, of course, there's some that still need it, but then if they do it, then the complication rate is going to be lower. If you stage it, everybody wants everything all done at once. I understand that, but that does really, the risks go up significantly, and I can't really emphasize that enough, because you don't, everybody thinks, oh, they're not going to happen to me, but until it's really can be a hard road if you do get a complication.
Especially adding skin resection, tummy tuck, all that stuff. I think the risks might outweigh the benefits in these cases.
Yeah.
Yeah, I'm with you. Talking about that, what's your thoughts about large volume liposuction? Some people are like taking, 10, 15, 18, 20 liters at a time in one setting. What's your thoughts on that?
Well, of course, that the complications go up the larger the volume. Now, there was a great study by Chow in PRS, plastic and reconstructive surgery, and that so larger ladies do tolerate larger volume in liposuction removed, but I really don't. I don't have a hard limit, and there's no limit in Missouri. So I have removed more than 10 liters, but my average is right around 5, and I it's just very larger ladies and I really was not intending to remove more than 10 liters. That's really sort of my upper limit of what I feel should be safely done. But sometimes you put 10 liters of tumescent expecting to get 10 liters out, and you get 12, and that has happened a few times. And so, yeah.
Yeah. And I'm with you. And I think safety is key. Like, kind of like when you say around that 5 liters, and especially if somebody is not it's just very safe. It's a very, very safe operation. You just really minimize the chances of complications significantly. And because unfortunately, you see, like, 17, 18 liters, the risk of blood transfusion goes up. The recovery is much harder. A lot of them end up ICU, fluid,
Right.
Foley catheter, central lines. Yeah, just the last thing you want to do. I know the idea is great. You're like, yeah, you just do it and then that, but
Yeah.
it's like driving 100 miles per hour on the highway. The chance of something happen at that speed is much higher.
For sure, for sure. And so I said my average is 5 liters, and I try. I mean, I feel like the very large ones, that we really are. They're going to get lightheaded and all that. There's going to be a combination, more risk of anemia, that sort of thing. Yeah.
You mentioned something about a study that you've done recently about a 5% drop in the hemoglobin. Would you tell us more about it now that we're talking about like high volume and
Yeah, that's my study. Yeah, so it was about over 200 or 500 cases, and we followed the pre and post hemoglobin, and about 5% had a 2 gram drop in their hemoglobin, and so you know um, I mean that they no one needed. I mean, no one needed a transfusion or anything like that. But they're more prone to be, feel lightheaded for 6 weeks, 8 weeks sometimes before they really feel get their vim and they feel strong again. But so yeah, I mean it does. I mean it'll. That's I mean, I think that's about as far as I want to go.
yeah, and that's impressive. And these are actually very good numbers. I mean, like 5%, 2 grams up. I mean, this is great, great. And somebody with you, like who's doing vein. I mean, that tells you like it's not a joke surgery. It's still like 2 grams people would feel it, and somebody who's like you treating the veins, doing the right thing, done it so many times. And so, when was the post-operative hemoglobin taken? Like, how far after the
So,
procedure was it taken?
oh, that was actually just a few days after. So it's usually like 3 days. The average check was 3 days after surgery.
Yeah.
So
So,
and
so
I
part
I
of, go ahead.
so there may be a little
Yes,
hemodilution in that.
yes, which is even make the numbers even better. Because if like part of it is hemodilution, that means like it's even like this is very minimal loss in these cases. What? So you think the 2 grams of hemoglobin? You think how many drops you think people would need to be symptomatic, kind of lightheaded dizziness? You think one, two, three? At what level you think they would feel it?
I think it's variable because I'm going to go on a segue. Sorry about this, but we have a lot of people with EDS, and they have a lot of issues with postural hypotension, anyways. And so we see that a lot in lipedema. So I think almost everybody gets a little lightheaded post-operatively, and they feel without out of their compression, they're going to get lightheaded for a few weeks even. So I don't know, but when they do have a greater drop, they tend to be more symptomatic.
Yeah, yeah, I agree. I had a patient, she had a hemoglobin of 13 and she dropped to like 9.8, about 3 points,
Yeah.
3 to 4 points up. I mean, she felt it. You look at her, you think, oh my God, like she would need transfusion. She didn't. I mean, she had like 9 to 10 here, but she lives at
Yeah.
13. So you
Yeah,
can
right,
tell,
right.
kind of the same thing, varicose veins, massive weight loss, all that stuff, treating it without, and this is like the most you would feel it. So that's why I feel like, when they hit the fourth, even though their number is still high, like transfusion, numbers at seven and below, you would give them blood, but even at that, they would feel it. So even though they don't need blood, symptomatically, they would need it.
Yeah,
They
for
would
sure.
need it.
Yeah. I mean, they look washed out,
Yes.
and yeah.
Yep. Iron, vitamin B12, all that stuff would help it. So, I mean, I couldn't agree more. Like I love what you're doing on the study side and really make, because we have like there's not much in the literature about stuff like what you're doing. There's none. Like, you know, we can ask each other, but like for publications and physicians and patients to
Yeah.
look at, that's really none. I mean, you don't know.
Yeah.
Do they drop one point?
Yeah, Michael Schwartz also looked at, and he did a presentation at the FDRS. He also looked at hemoglobin, but he hasn't published it, unfortunately,
Okay.
yet.
What was the drop in his? I don't know if you remember. We'll see. Hopefully, if he presents this
It
year.
was kind of similar. I don't know. It was actually, I think, a little
Okay.
more, but I don't know.
Yeah.
But you know, again, so that 2 gram was what, you know, that was the average for those people.
Yeah. And I think that's kind of. I actually think probably it's much more than that. You know, if you go across, especially if somebody who doesn't do like high volume lipedema, they're probably gonna be much higher than that. And if they do high volume, of course, it's gonna be much lower drop. We do have a lot of questions. However, I know we're getting to 1 hour, and I promised it's a 1 hour live. We might need to do another one in any, you know, like I cannot tell you how much I personally learned. And I have actually, I was taking notes as I personally learned a lot, so I'm really more excited about these lives than our audience. But if you guys please check out Dr. Wright. He's awesome, a wonderful surgeon, a wonderful human being, and check out his Insta and follow him. And it's just it's always a joy and a pleasure of having you here, Dr. Wright. I really enjoy it.
The feeling is so mutual. I could do this all day. Unfortunately, we both have you know demands other than Instagram Live. Yeah.
Yes, we do. Awesome, Dr. Wright. I'm looking forward to seeing you in person at the FDRS.
Me too. Me too.
It's going to be great. I'm excited for it. And again, I really, really appreciate your time being here today.
Oh, I really appreciate you having me on and talking. This is a lot of fun for me, and I really enjoy it.
Love it. Thank you so much. Have a wonderful day. Thank you, everyone. Thanks, guys.
Okay.